Thank you. Dear Chairman, dear colleagues, I'm very glad today to present this study. And this study follows the study I presented last year in Florence. Some of you might remember we used a large cohort of chest pain patients presenting to the emergency department. And in this secondary analysis, we looked at patients with active or past cancer and confronted them with non-cancer patients. Among more than 8,000 patients, we had 711 cancer patients. So we found out that non-STEMI prevalence was higher in cancer patients. And non-cardiac chest pain was less prevalent in cancer patients, differently from what we thought initially. And then the diagnostic performance of troponin T, but not that of troponin I, was reduced in cancer patients. Nevertheless, the ESC 01-hour algorithm for both troponin, the rule-out, the sensitivity for rule-out was the same in cancers versus non-cancer patients, while ruling specificity was lower in cancer patients for both troponins, and more importantly, the observed zone proportion was much higher in cancer patients, so nearly double the number of cancer patients were triaged to the observed zone. And the most common final diagnosis in this group was non-cardiac chest pain. So that's why we did this further secondary analysis, and we aim to derive new cutoffs for both algorithms, for both troponins, and then to evaluate the one-year outcome prediction by the new triage groups. So what we did. In the methods, we used again the APACE cohort, which, as you remember, is a large international prospective diagnostic study and enrolling patients presenting to the ED with chest pain and excluding those on chronic dialysis. So we used patients with active or past cancer that had both troponin at 0 hour and 1 hour measured. And so we tested multiple cutoffs that would provide us with a negative predictive value above 99% and a positive predictive value above 75%. Then we checked the diagnostic performance measures with a bootstrap internal validation approach. So we took multiple random samples to get optimism-corrected values for the diagnostic performance measures. And then we did finally a sensitivity analysis applying the newly found algorithms in all cancer patients in whom it could be applied. So not only in those who had both troponin measured. So let's jump to the results. Among 666 cancer patients, 163 had a final adjudicated diagnosis of non-STEMI. The others had an alternative diagnosis. Among non-STEMIs, patients were older with more cardiovascular risk factor, more coronary artery disease, and worse renal function and lower hemoglobin, as expected. So for the troponin T assays from Roche Alexis, for the rule-out, the original algorithm had a cutoff of 5 for the 0-hour cutoff with a chest pain onset greater than 3 hours, while the general rule-out cutoff at 0 hour was 12 with a delta of 3. The newly derived cutoffs were 8, 14, and the delta remained the same. For the 0-hour ruling, the original algorithm had a cutoff of 52 with a delta of 5. The newly found algorithm had a 0-hour cutoff of 54 with the same delta. For the architect troponin I assay, the rule-out cutoff at 0 hours with a chest pain onset greater than 3 hours was 4 in the original algorithm, while the general rule-out at 0 hour was 5 with a delta of 2. The newly found cutoffs were 7, 10, and a delta of 3. For the 0-hour ruling, the original algorithm had a cutoff of 64 with a delta of 6, and the newly derived algorithm had a 0-hour cutoff of 61 with a delta of 5. So when comparing the old versus the new algorithm, we found no difference in sensitivity, negative predictive value, specificity, and positive predictive value. The results that you see here are for troponin T, and this is what we wanted. While we had a steep increase in efficacy, which was statistically significant, and that means that less patients were triaged to the observed zone. And this was also true in the sensitivity analysis. For the outcome prediction, we can see that patients triaged to the observed zone, you see in yellow, at 1 year they had a greater all-cause death, which was mainly due to non-cardiovascular death. The limitations of this study. Non-specific sample size calculation was carried out, and sample size was too small to carry out subgroup analysis within cancer patients, so for example, active or advanced cancer. And external validation is yet to be done, and any help is really welcome, so please volunteer. In summary, we found out that the new ESC algorithms for both troponin T and I in cancer patients have a better efficacy, so they triage less patients to the observed zone. Patients in the observed zone, however, have a higher risk of all-cause death, which is mainly due to non-cardiovascular death. And so some of you might ask yourself if we really need new cutoffs to learn by heart. Of course, no. But what the conclusion of this study could be is that the rule out of non-STEMI in cancer patients is still very safe when using slightly higher cutoffs. Thank you.
Thank you very much. You were on time. This is perfect. We have 3-minute questions from the room, from the jury, and from the chair. Yeah, please, Frank and Joseph.
So cancer is one of those broad diagnoses that goes from basal cell carcinoma, which means nothing, to metastatic lung cancer, and you're dead in 2 weeks. So how do you sort that out?
Yes, thank you for the question. This is true. Cancer as we defined it, so we only excluded MGUS as an hematological malignancy and skin cancer, non-melanoma skin cancer. So we basically got all cancer that could get metastatic. But it is a broad group and with patients with very different characteristics within it. So in order to address the different subtypes of patients that we can get included in the whole cancer group, we should have a greater sample size and to perform subgroup analysis, which are of course very important and could get insights to differentiate among cancer patients and within them.
Joseph?
Was it the same way you could distinguish between active or kind of cancer, but it's difficult to put in the same bag all cancers? Because
yeah, it is true, but it's also interesting that even if we put very different things and clinical entities together, we still get those results. So I think this is
Great
still
question from Nick. Last question.
Great presentation. Very happy to help if we can. My question is why? Why do you think cancer patients have, it's more challenging to rule in? What do you think the mechanisms are? And do you think that's specific to cancer or cancer therapies? Or there's obviously some reason why troponin concentrations are higher in these patients with cancer. What's the mechanism?
Thank you. I think in university we are thought of cardiovascular risk factor as atherogenic risk factors and or non-atherogenic risk factors, and I think we should go out of this binary classification, and maybe cancer can induce acute coronary syndrome by very different mechanism, but I think we could consider it as a new cardiovascular risk factor, maybe mostly non-atherogenic, maybe, but surely cardiovascular risk factor.
Thank you.
Thank you.